This video is about respiratory disorders of the newborn. The learning objectives include recognizing respiratory distress, identifying common conditions and risk factors, and understanding basic management principles. Respiratory distress in a newborn is abnormal breathing with increased work of breathing, tachypnea, and/or hypoxia. Respiratory distress is a common neonatal problem and a major cause of NICU admission. It can also be life-threatening. During the transition, fetal lung fluid is cleared at birth, surfactant stabilizes alveoli, and pulmonary vascular resistance falls, enabling effective gas exchange. Clinical signs of respiratory distress include tachypnea, grunting, nasal flaring, chest recessions, and cyanosis. Apnea is considered severe. Causes can be categorized as lung-related, air leak-related, pulmonary vascular, structural, cardiac, or systemic. Risk factors for respiratory distress include prematurity, C-section, meconium-stained liquor, maternal infection, and birth asphyxia. Clinical clues can point to the cause. Preterm babies often have RDS, term babies with mild symptoms may have TTN, and severe term symptoms suggest MAS or PPHN. Immediate severe symptoms indicate a structural issue. Investigations typically include arterial blood gas, chest X-ray, and a sepsis screen. Surfactant-deficient lung disease is associated with prematurity, maternal diabetes, and surfactant protein deficiencies. A chest X-ray may show a ground glass appearance. Surfactant deficiency leads to increased alveolar surface tension, resulting in atelectasis, heterogeneous lung expansion, unventilated atelectatic areas, and overdistension of ventilated regions. Transient tachypnea of the newborn, or TTN, starts within the first 2 to 4 hours after birth due to delayed fetal lung fluid clearance. It peaks around 6 to 12 hours. Meconium aspiration syndrome, or MAS, occurs when fetal distress causes increased intestinal peristalsis and relaxation of the anal sphincter. The baby then gasps, aspirating contaminated amniotic fluid, meconium, blood, and debris. In MAS, bacteria and infection cause direct mucosal injury, surfactant dysfunction, and pulmonary edema. Mechanical airway obstruction, inflammation, and debris trigger vasoconstriction, leading to PPHN. Tracheo-esophageal fistula, or TOF, symptoms include respiratory distress, excessive salivation, choking, and cyanosis during feeds. An NG tube cannot be passed. Air leak syndromes include pneumothorax and pulmonary interstitial emphysema, or PIE. Pneumomediastinum is discussed next. Pneumomediastinum is an air leak syndrome where air escapes from the alveoli into abnormal spaces. Causes include mechanical ventilation, RDS, MAS, and high airway pressures. Persistent pulmonary hypertension of the newborn, or PPHN, is a serious, life-threatening condition where blood vessels in the lungs do not relax after birth, preventing adequate oxygenation. Causes of PPHN include meconium aspiration syndrome, pneumonia, sepsis, surfactant-deficient lung disease, congenital diaphragmatic hernia, and asphyxia. Cardiac causes of respiratory distress include congenital heart defects, such as cyanotic defects, left-to-right shunts, left-sided obstructive lesions, and duct-dependent lesions of the pulmonary circulation. Infective causes of respiratory distress include neonatal pneumonia, neonatal sepsis, and chorioamnionitis. Risk factors for chorioamnionitis include maternal infections, prolonged rupture of membranes, and prematurity. Neurological causes of respiratory distress often manifest as apnea rather than tachypnea. Risk factors include prematurity, hypoxic ischemic encephalopathy, and maternal medications like sedatives or illicit substances. Metabolic causes of respiratory distress include hypoglycemia, inborn errors of metabolism, and metabolic acidosis, which can be due to sepsis. Hematological causes include severe anemia from acute blood loss, hemolytic disease of the newborn, or twin-to-twin transfusion. Polycythemia from delayed cord clamping, IUGR, or an infant of a diabetic mother is another cause. Other causes include laryngotracheomalacia and congenital diaphragmatic hernia. Management involves initial stabilization following the ABCD protocol, oxygen, surfactant therapy, respiratory support, IV fluid/nutrition, antibiotics, minimal handling, and treating underlying causes. This image summarizes some of the key concepts discussed in the video.